We are not expecting many people today. I think our two batches are there and some people.
Yeah, maybe we
So,
can go ahead. We can get started, Dr. Ajit, in the interest of
yeah,
time.
yeah, 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 yeah. We can get started. So, hello everyone. Good morning. How are you all? And I hope you know that we have started, the new things and new courses, new trainings for all students, faculty members, and the professionals, young professionals, to upgrade themselves into the, different domains of HEOR and, RWE, HTA, and many more things. So we have started IHEPR. That's more than a month. And with that, this is the first workshop along with that webinar, what we have done on the occasion of inauguration. So, guys, this is a very technical, workshop. I'm not going to, describe that because I don't know anything about it, frankly, if I say. Okay. But other than that, I would like to welcome you all to join our, two programs. Those are very good. One is our upcoming systematic review and meta-analysis 3 days short course, right, which is on 17th, 18th. And let me just show you if I get a minute. Let me just show you 1 second. Give me a minute, just guys. Okay. I'll
I was
just show you.
about to share, Dr. Ajit, but if you have, then I won't. Okay.
अच्छा ओके 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 नो आप भी शेयर कर दीजिए बाद में नो प्रॉब्लम
Okay,
सो
okay.
आई थिंक आई
That's
हैव
fine.
दैट
Okay,
यू
then.
आल्सो शेयर नो वरीज ओके
No, no
एंड देन
problem.
and one more thing was there. Yes, yes, these two things I wanted to share with you because these are very amazing thing what we are, coming up with. And I really want all of you to explore these things. Right. So let me share. First is, as I was telling you, that this, 3 days course, 3 days short workshop, 3 days practical workshop on AI integrated systematic review, meta-analysis, and network meta-analysis writing and publication. And the best perk of it is like you will be giving a chance to write a systematic review. If you are interested, you can join our network and we can start the publications. We can, help you in publication and we can help you in, creating, from the very start a systematic review or meta-analysis or whatever you want. If you are enthusiast, you can join us and you will get an opportunity. And you will see we have, really wonderful syllabus you go through later and wonderful, speakers with us, who will be taking all the classes. And the fees for Indian participant is just 750 INR. And for, international participants, it is 50 USD, right? So you can immediately, join that. We can share we will share definitely these in the groups. And the next part is Executive Diploma in Health Economics and Outcome Research, HEUR. So this is again wonderful course. Why I'm telling you is for the beginners and for the students to understand HEOR and to get the basic knowledge and the little bit more about it, little bit more about the domains and how the things work. Right. You can join this. And along with that, we have the syllabus which is dedicated for the people who are here to understand the advanced versions of it, like economic evaluations, outcome research, and a lot of things like HTA and HUR applications, market access. So it is like from basics we are starting. So it is like you don't need to have the prerequisites to learn this, right? You can join and we will teach you from very basic to advanced version in 6 months. And in these 6 months, 2 months of internship is also included, right? This is a 6 months diploma. So 4 months of theory classes and 2 months of internship in the real-time projects. Okay, you can join this, and the course fee is 18,000 INR for Indian candidates, I believe, because we have a lot of funds before starting it introductory funds, right? So the fees is 18,000 and you can pay it in two times, like 10,000 plus 8,000. Okay. And this is for entire, including internship for entire 6 months. Okay. So this is the second course, and third course, third thing, if I just want to say, we are going to launch it, but it is like I'm just showing you. This is the fellowship in HTA and policy research. Okay, so if you're interested, you can just go to our website ihepr.org and you can apply through there. Okay, so with that, guys, first of all, I would like to thank you all for joining, and I would like to thank our partner Dualisphere and Ms. Sarmila ji for taking this wonderful session. And over to you, Dr. Richa. I think that's all what was, in my account to speak. Over to you, Dr. Richa. Thank
Thanks,
you.
Dr. Ajit. Hi, everyone. Good morning, good afternoon from various parts of the world where we are joining. And as Dr. Ajit said, we came up with IHEPR, Institute of Health Economics and Policy Research. At the end of the session, I'll share with you the QR codes and the links for our LinkedIn page, our website, where you can follow us, you can explore so that you don't miss any opportunity to learn. That is our perspective. And we will also be coming up with a page where we'll be posting some of the job opportunities, some of the career enhancements very soon, so that it kind of becomes a one-stop shop for all of you, where you can search about the upcoming opportunities, right, Dr. Ajit, and apply henceforth. Through our courses, we ensure that we will train you so that you are able to give those interviews. Coming with an experience of almost 2 decades in HUR industry, I thought, and all of us, we, Dr. Ajit, and our teams, respective teams, we thought of building something which is beneficial for students and working professionals. Right. So keep on following us, liking us, subscribing us, as they say, for more updates on the courses. Right. Let's start with today's session. Okay. Closing all other distractions on my laptop. I'll just share our screen. Okay. I'll switch off my video and here we go. I'm making it full screen. I hope it is visible to everyone.
Yes.
Yes, Richa.
Okay, let's go ahead, guys. Okay, let's start with Global Value Dossiers, GVD 2.0, and HTA Evidence Strategy. How many of us have developed a GVD? Just a quick question so that I can have the knowledge level. Maybe not the entire GVD, maybe parts of it, just the clinical section, economic section. Answers? Yes, no. No marks will be deducted if it is a no. No problem. Okay, let me see the answers. Yes, no, 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 no. Okay. Okay, great. Let's start this and let's see today what me and Sharmila will take you through. Quick introductions of ourselves. Myself, Richa Goyal, founder and CEO of Dualsphere Consulting, and recently we collaborated with the CLIMED, and that's very kind of Dr. Ajit, and we came up with IHPR, for which both me and Dr. Ajit serve as founders and directors of the board. Okay, so let's start. Right. So, what are we going to discuss today? So, in today's session, we will introduce you to GVD 2.0. What is the meaning of that? What is the structure and component of effective GED? What is the architecture? What is the best practice? How many days it takes for a GVD to form? How many QC processes are there? How to make it? What are the expectations when we get evidence from payers, providers? What is the evidence that goes from secondary research? Is there any primary research required? What it is? What is the role of modeling in that aspect? What is the role of cost effectiveness model, budget impact model, ICER interpretation? How value communication fits in? What are the common challenges, and when do you think it is submission ready? And most importantly, where does the global value dossier goes? Who is the taker for it? Who is the target audience? So we will address the problem statements like who develops the GVD, why it is needed, and once it is developed, who is the taker for that GVD. Okay. Now, moving to the next slide. Why global value dossier matter? So it's the cornerstone of market access strategy. It's a document that it is submitted for any HTA submission, HTA approvals, market access strategy, and it transforms the clinical, economic, and other raw evidence into a structured narrative. Right. So it collects data from clinical evidence, from pivotal clinical trials, HUR analysis, secondary research, pharmacoeconomic modeling, budget impact model, cost effectiveness model. It depends. You have to do a de novo model or a country adaptation of various models. Then global value dossiers are crafted. Then they are tweaked for the local adaptation. They are local value dossiers, and then they go for HTA submissions. So there is a lot of strategy which goes. Can service providers like us make the GVD alone independently? Yes, we do, right? We do collect the evidence, but it is always done in consultation with the pharma company or the payers or the provider. Can you please mute yourselves, every one of you? Yeah. Admin, can you please mute everyone except me? Yeah. Thank you. Thank you so much. Okay. Uh, a lot of strategic discussions go along with it, right? So we keep on having our discussions with the pharma company who commissions us global value dossiers, HTA body people, the payers, if provided, KOLs, patients, everyone becomes a part of it, right? Now, for more technical aspects, I hand it over to Sharmila to take you through the details of GVD 2.0, what goes into it. Sharmila, over to you, please.
Yeah, thank you. Richa, I'll share the screen. No issue. You can
Oh,
stop
thank
your
you so
screen.
much. Thank you.
Yeah.
Thank you.
Yeah.
Okay, go ahead.
Hope you can see my screen, right?
Yes, Sharmila, please go ahead.
Yeah. Okay. Now, yeah, I'm Sharmila. I'm Associate Director in Geosphere Consulting. Uh, Anyways, Richa told the introduction, what is GVD and all. Now we know why GVDs matter, right? So let us understand what makes GVD2 different. Okay, so uh, this slide actually compares traditional GVD with GVD2. Okay, a traditional GVD was often a static point in time document. It was usually prepared periodically. It was often literature heavy and narrative focused. It was sometimes owned by one function. But if it comes today's HTA environment, there is a lot of change. Okay, pairs are more sophisticated. They ask more detailed questions. They want local relevance. Okay, they expect transparency, economic models, and they want uncertainty to be explained, and they want evidence to be updated. The product cycle, life cycle, and all. So this is why GVD2 is needed instead of traditional GVD. Okay, so okay, GVD. Okay, GVT2 is if you come to GVT2, it is a modular living evidence system. So, modular means that different sections can be updated separately. For example, if new survival data becomes available, the clinical evidence section can be updated. If new RW becomes available, the RW section can be updated. Likewise, if a new competitor launches, the treatment landscape can be updated. And GVD2 is also cross-functional. It is not only by one department. It owned clinical, as we have seen in the last slide, clinical, HUR, medical affairs, market access, regulatory epidemiology, and local affiliation may all contribute. Okay, next, the GVD2 is payer-centric. That means the narrative is structured around payer questions, payer questions, P-A-Y-E-R, payer questions, not only scientific data. So GVD2 also adaptable by market and indication. So a product may have multiple indications. Different markets may need different value messages. So GVD2 supports that flexibility. But traditional GVD has no that, there is no that flexibility with traditional GVD. So let us take a practical example. Imagine a pharmaceutical company launches a new oncology medicine in 2026. Okay, at the time of launch, the company only has phase 3 clinical trial data. The GVD contains disease burden information, treatment landscape, clinical trial results, safety data, initial cost effectiveness model, initial budget impact model. Okay, this becomes version 1 of the GVD, right? You know, most of you have prepared some manuscripts or any documents. You have prepared version 1, version 2. So, likewise, this becomes the version 1 of the GVD. Now, imagine 1 year later, patients continue to be followed in the clinical trial. The company now updated overall survival data. In addition, patients are using the product in routine clinical practice. Okay, then real world evidence studies become available, right? Now, that is the real world evidence studies. Okay, now the company updates the GVD. The clinical section is updated with longer follow-up survival results. The RW section is added. The economic model is refined using the new evidence. This becomes version 2 of the GVD. Now let us move another year forward. Researchers discovered that the same medicine can also be used in another cancer type. So the product receives approval for the new indication. So the company now updates disease burden section, right? So clinical evidence section, economic evidence section, value proposition section to include the new indication. So this becomes version 3 of the GVD. So the GVD is continuously growing and improving throughout the product life cycle. It is no longer a document sitting on a shelf. It becomes a living evidence platform. It is not a document. Just we are not stopping. It is just continuing. We are updating the document. So that's why it is a living evidence platform. So this is exactly why we call it GVD2. Now, why this matters to HTA? Now let us think from a payer's perspective. Suppose NICE evaluated the product 2 years ago. At the time, only short-term survival data were available. Today, we may have longer survival follow-up, additional safety information, real-world effectiveness data, new QoL evidence. Would NICE want to see this new evidence? Absolutely, right, okay. Because reimbursement decisions should be based on the best available evidence. So a living GVD ensures that the latest evidence is always available for decision makers. Okay, for better understanding, we will take day-to-day example. I'll tell you, okay? So think about Google Maps. You all know about the Google Maps, right? 10 years ago, people used printed road maps. Okay. Once printed, the map never changed. If a new road was built, the map become outdated. But Google Maps works differently. It continuously updates. If a new road opens, it updates. If there is a traffic, it updates. So if a route closes, it updates. So because of these continuous updates, Google Maps remain useful and relevant. GVD2 works the same way. A traditional GVD is like an old printed map. A GVD2 is like Google Maps. Okay, and as new evidence becomes available, the dossier updates itself and remains relevant for payers, HTA agencies, and affiliates. Okay, so traditional GVDs were mainly evidence repositories, but if you come to GVD2, it's an evidence strategy platform. So modern GVDs integrate, we can tell like this, modern GVDs integrate clinical, economic, and strategy evidence into one payer relevant narrative. So now let us see where the GVD fits in the access chain. Okay, this slide shows a structured pathway from clinical development to payer engagement, right? So let us go step by step. Step 1 is clinical development. So this is where efficacy, safety, and patient-reported outcome evidence is generated, right? So for example, in oncology, clinical development may generate overall survival, progressive-free survival, response rate, adverse events, and quality of life. And if it comes to step 2, it is HEOR evidence generation. This is where clinical outcomes are translated into economic and access relevant evidence. Examples include burden of disease studies, utility data, cost effectiveness models, budget impact models, and resource use studies. And if it comes to step 3, it is global value dossier. This is the central evidence integration platform. It brings together all evidence streams into one cohort global value narrative. Step 4 is local adoption. This is where the global evidence package is adjusted to country-specific needs. So here, comparator, epidemiology, cost inputs, resource use, local guidelines, and payer priorities are updated in the local adaptation. Okay, and if it comes to step 5, it is HTA submission and payer engagement. So this is where the localized evidence package supports reimbursement decisions and payer negotiation. Now, the key insight on this slide is very important. Okay, The GVD is not the same as the HTA submission. The GVD sits upstream. It prepares organizes the evidence. The HTA submission is a local application of that evidence. So if you see the professional example, for NICE, the company must prepare a specific evidence submission aligned with NICE methods. So that is the local adaptation for UK. Okay, the GVD can support this submission, but it cannot simply be submitted unchanged. The NICE submission will need local comparators, UK cost, UK clinical practice assumptions, economic modeling aligned with NICE expectations. So now, I not just want to just sit there. I want to let you understand how this GVD fits into a complete access journey using a diabetes product example. Okay, imagine a pharmaceutical company develops a new diabetes medicine. Understand, please. Okay, the product enters clinical trials. Researchers compare it against the current standard treatment. After several years of research, the trial shows that patients receiving the new medicine experience a significant reduction in HbA1c levels. So, as many of you know, HbA1c is an important marker because it reflects long-term blood glucose control. So the trial may also show reduced risk of hypoglycemia, weight reduction, better cardiovascular outcomes, and improved quality of life. This is the first stage of the access journey, okay? The next stage is clinical evidence generation. So what we are seeing in the slide, HUR evidence generation. So at this stage, we know the medicine works, but from the payer perspective, another question immediately arises. Is this additional benefit worth the additional cost? This is where the HUR team enters. The HUR team takes the clinical trial results and converts them into economic evidence. For example, if better HbA1c control reduces future complications such as kidney diseases, heart attacks, stroke, or hospitalization, these benefits can be translated into economic outcomes, right, guys? Right? Because along with the disease, if there is some complications with the drug, it again costs the patient, again cost for the patient or for the payer or anybody. So, if there is no complications, when the payer will see HbA1c control reduces future complications or not. Okay, these benefits can be translated into economic outcomes. Okay, the HUR team may develop to check this, all the things, economic outcomes and all. What are the benefits and all? The HUR team may develop cost effectiveness models. What is cost effectiveness model? This model estimates what is the additional cost, what is the additional quality, and ISO. So that model may show that although the medicine costs more today, it prevents expensive complications in the future. So the cost will reduce, right? The overall cost will reduce. Then the HUR team also see the budget impact model. So what is this? The payer may ask what happened If thousands of diabetes patients start using this medicine, then the budget impact model estimates number of eligible patients, annual treatment cost, potential savings from avoided complications. I'll show, if anybody don't know about the budget impact, I'll show a small example after. Okay, just now you have. So net budget impact over 3 to 5 years. Now we move to the next stage, that is global value dossier. Okay. At this point, all evidence is brought together, right? The clinical, say, clinical development or HTA outcomes and all. And all evidence is brought together. So now the GVD integrates disease burden, treatment landscape, clinical evidence, safety evidence, patient-reported outcomes, cost effectiveness results, budget impact results, and value propositions. So the GVD creates one clear global value story. The story may be the diabetes treatment improves glycemic control, reduces complications, improves patient outcomes, and may provide long-term economic value. Like this, it will create a story. But we are still not ready for HTA submission. The global value dossier reports, but we are not still ready for HTA submission because every country is different. Now comes local adaptation. Okay, suppose the product is being introduced in India. The Indian affiliate cannot simply copy the global evidence package. They must adopt it. For example, epidemiology. The number of diabetes patients in India is very different from many other countries. India has one of the largest diabetes population in the world. Therefore, eligible patient numbers must be updated. Okay, then comes to local cost like hospitalization cost, medication cost, monitoring cost, consultation cost, and laboratory testing cost. So all this must reflect Indian healthcare settings. So then comes to current standard of care. The treatments commonly used in India may differ from those used in Europe or North America. So comparators must therefore be adapted. Then comes affordability considerations. Payers may place greater emphasis on affordability because of the large patient population with diabetes. So finally, the adapted evidence package becomes part of HTA submission and payer engagement. Now the payer reviews clinical value, economic value, budget impact, and local relevance and makes a reimbursement decision for India. Here we are coming. It is local adaptation. Okay, so this entire journey demonstrates how evidence travels from the laboratory to the payer's desk. And the GVD serves as the central bridge connecting all these stages. Okay, so this example is powerful because notice that at each stage, the evidence becomes more decision-oriented. Clinical trial answers, does the medicine work? HVR answer, is it worth the cost? The GVD answers, what is the overall value story? Local adaptation answers, what does this mean for my country? HTA answers, should we reimburse it? So this is the complete access journey. If you take, I want to tell for easy understanding or real life example, like imagine you want to build a house. First, an architect designed the house. This is like the clinical trial. It proves a concept. Next, an engineer estimates construction cost, materials, long-term maintenance cost. This is like HEOR. Then all plans, designs, and budgets are compiled into one master project file. This is like a GVD. Now, suppose the house is being built in different cities, the design may remain similar, but local modifications are needed, right? This is local adaptation. Because we want to see the land prices, construction cost, weather conditions, building regulations, and all. So this is the local adaptation of that city. So finally the local authority reviews just as the house cannot be approved using only an architectural drawing. A medicine cannot receive reimbursement using only clinical trial data. Okay. So, admin, please mute all the other users if possible. So, multiple types of evidence are required, and the GVD brings them all together. Okay, so in this slide, the key takeaway is clinical trial proves efficacy, HEOR demonstrates value, GVD integrates evidence, local adaptation make evidence market specific, and HTA submission supports reimbursement. Here you need to remember that GVD enables global consistency, but local adaptation enables country relevance. So both are necessary. Okay.
Hello.
Sorry, Richa.
Okay, no problem. No problem.
Yeah. There
Continue.
is power cut. Yeah.
Okay,
1
okay.
minute.
Please.
Yeah.
Yeah. Please continue.
Yeah. Now we will go into the internal structure of the global value dossier. Okay. This is one of the most important slide. So the slide shows 11 interconnected evidence modules here. Okay. A strong GVD, if you see a well-structured or a strong GVD, is organized in a logical sequence. It starts by explaining the disease, then it explains the current treatment environment, then it introduces the product, then it presents clinical safety, patient-reported outcomes, HEOR, and RW evidence. Then it builds the value proposition. So then it acknowledges evidence gaps. Okay, finally, it supports local adaptation. So let us go one by one. First one is disease burden, right? So this section answers the question, why does this disease matter? So it includes epidemiology, humanistic burden, and economic burden. For example, in diabetes, disease burden may include prevalence, complications, hospitalizations, productive loss, and quality of life impact. In cancer, it may include incidence, mortality, treatment burden, caregiver burden, and survival impact. And when it comes to second one, it is a treatment landscape. So this section explains current standard of care, treatment pathways, unmet needs, and comparators. Okay, payers want to know what patients currently receive and where the gaps are. And comes to third one, it is product profile. Here, this explains the mechanism of action, dosing, licensed indication, administration, and target population. So this section includes introduce the product essence scientifically, and come to fourth one, it is clinical evidence. So this includes pivotal trials, indirect comparison, and meta-analysis. So for HTA comparative evidence, it is very important. Okay, so payers do not only ask whether the product works, they ask whether it works better than the relevant comparator. So fifth one is safety profile. So this includes adverse events, tolerability, and benefit risk balance. And safety is important because treatment benefit must be weighed against treatment burden. Then comes to sixth one, it is patient reported outcomes. This include HRQL, patient reported instruments, and utility values, etc. Okay, whichever come under PR. Okay, this section is important because patients may value symptom relief, daily functioning, reduced fatigue, emotional well-being, and improved quality of life. Then comes to seventh one, that is HOR. Okay, this includes cost effectiveness and budget impact models. This section helps answer payer questions about value and affordability. Okay, next one is real world evidence. This includes real world data sources, treatment patterns, and also adherence, persistence, and real world outcomes. So RWE helps show how the product performs outside control trials. Then comes to ninth one, it is value proposition. This contains the core messages, differentiation, and clinical relevance. And this is the heart of the GVD. This value proposition is the heart of the GVD. Okay, it answers why should payers consider this product valuable. Okay, next is evidence gaps. And evidence gaps, it includes known limitations, any known limitations, ongoing studies, and areas of uncertainty, like that. So a strong dossier, we can say, if it is a strong dossier, it does not hide any limitations or anything. It acknowledges them and explains mitigation plans. So then the last one is local adaptation. Already we have seen. So this includes country-specific inputs, payer contest notes, and this helps affiliates adopt the global dossier to local HTA requirement. So let us understand this entire structure. I want to just describe it, understand the entire structure of the GVD using a real life multiple myeloma example. Okay, imagine a pharmaceutical company is launching a new treatment for patients with relapsed or refractory multiple myeloma. The payer will not reimburse a product simply because it exists. the company must build a complete evidence story. Each section of the GVD contributes one piece of that story. So let's walk through each component now with this example. Okay. So if it comes to disease burden, why should anyone care about multiple myeloma? Why? Every value story starts with the disease burden. Before discussing the medicine, we must explain the problem. Think like a payer. Think like a payer. If I am going to spend healthcare resources on a treatment, I first need to understand the magnitude of the problem. Okay, in multiple myeloma, if you take this example, one of the biggest challenges is relapse, right? So even after initial treatment, many patients eventually relapse and require additional lines of therapy. So each relapse often becomes more difficult to treat. Patients experience disease progression, bone pain, fractures, kidney complications. Okay, frequent hospital visits and reduced quality of life. So there is also significant caregiver burden too with this in this disease. So families spend time and money. They are supporting patients through repeated treatments and hospitalization. So the disease burden section answers, why is this disease important enough to deserve investment and reimbursement? Right? Okay, for better understanding, we'll see one day-to-day example. Imagine your house has a small crack in a wall. You may ignore it, but if the crack keeps growing every year and eventually threatens the entire structure of the house, it becomes a serious problem. So, disease burden is essential, showing how big the crack is. Before fixing the problem, we must understand the seriousness of the problem. Next comes to the treatment landscape. Once we understand the disease burden, the next question becomes, how are patients currently being treated? That is treatment landscape. So in multiple myeloma, patients may receive proteasome inhibitors, immunomodulatory agent, anti-CD38 therapies, and stem cell therapies, and some combination therapies too. So now the pair asks, if treatments already exist, why do we need another one? This is where unmet need becomes important. For example, current therapies may work initially, but lose effectiveness after relapse. So patients may develop resistance. Toxicity may limit long-term use. Some patients may have very few options after multiple lines of treatment. So this creates an unmet need. The treatment landscape section helps demonstrate why a new therapy is necessary. It is likely that, imagine your mobile phone battery. You already have a charger, but if a charger stops working properly after a few months, you need a better charger, right? So the treatment landscape section explains why current solutions are not fully solving the problem. Next comes the product profile. Now we introduce the product. The payer needs to understand what is the therapy, how does it work, what makes it different. For example, suppose the new treatment is a BCMA targeted therapy. The dossier explains mechanism of action, dosing schedule, route of administration, and target patient population. So this section provides the scientific identity of the product. If you see our real life example, before buying a car, you want to know engine type, fuel efficiency, features of safety rating, right? The product profile section serves the same purpose. Okay. Then comes the clinical evidence. So this is usually the first section most people think about, this clinical evidence. But clinical evidence provides proof that the treatment works. For multiple myeloma, key outcome may include progression-free survival, overall survival, response rate, and duration of response. Suppose the clinical trial shows patients receiving a new therapy remain progression-free for significantly longer compared with the standard treatment. The payer now has evidence that the treatment improves patients' outcomes. Like if you take an example, day-to-day example, imagine buying a new water purifier. The company claims it is better. You would want proof. Maybe laboratory testing shows it removes more contaminants. Like that, clinical trials or the laboratory test of healthcare. And clinical evidence alone is not enough. The payer also wants to know whether the improvement is meaningful. Then comes to safety profile. What risks come with a benefit? All of us know every treatment has risk, right? Now the payer wants to understand the adverse events, serious adverse events, and any discontinuation rates. So a therapy with excellent efficacy but unacceptable toxicity may not be considered valuable. Therefore, the dossier must show the balance between benefits and risk. If you see real life example, I can tell, imagine a sports car. It may be extremely fast. But if the brakes are poor, would you feel comfortable driving it? Probably not. So safety completes. Okay. Now comes to patient-reported outcome.
Sharmila, sorry to interrupt. We are half time over. We have a lot to cover. Okay.
No problem. Yeah. Okay. Yeah. So here, clinical endpoints are important, but patients care about daily life. Now comes to HOR evidence. Now we move into the HOR sections. This is where clinical outcomes are translated into economic value. So the HOR section may include cost effectiveness analysis, where the model estimates incremental cost, incremental qualities, and ISR, and budget impact analysis, where the model estimates eligible patients, total payer expenditure, and potential savings. Suppose the new therapy costs more, the payer asks, why should I pay extra? That's what the HOR analysis demonstrates, whether the additional clinical benefit justifies the additional cost. Okay, so then comes to real world evidence. Here, the company will check what happens outside the clinical trial. So this is becoming increasingly important because clinical trials occur under controlled conditions. But real world practice is different. The patients may miss doses, have comorbidities, switch therapies, and stop treatment. So, RW helps answers how does the treatment perform in routine practice. Okay, then comes to value propositions. Why should the payer reimburse, right? So now all evidence comes together, the value proposition answer, why is the treatment valuable? Okay, whether it is improves progression, delays relapse, improves quality of life, like that. Okay, and comes to and provides acceptable economic value compared with existing therapy. So this will become the core reimbursement message. Okay, like when you buy, like now the next one is evidence gap. So what don't like we know yet about that product. So a strong GVD is honest. It identifies remaining uncertainties. Long-term survival data may still be immature. So head-to-head evidence may not exist. Instead of hiding limitations, companies explain them and propose future evidence generation. Then comes to local adaptation. Already we discussed about this local adaptation. Okay, so think like this for your better understanding. A GVDS is like a building a court case. Okay, so only when all pieces come together does the payer have enough confidence to make the reimbursement decision. So if you are preparing a GVD for a new product, all the sections like clinical evidence, comparator, survival outcomes, safety, cost effectiveness, budget impact. So all will, but RWE will be most important for payers. But the strength only comes from how they connect. Okay, now that we know the structure, let us understand what makes the GVD effective. Okay, so this slide shows 5 defining characters of high impact GVD. Okay, a dossier can contain a lot of evidence but still be ineffective if it does not communicate value clearly. So the first character should be clear value proposition. So a value proposition should be concise and differentiated. It should clearly explain clinical and economical benefits. Now, let us discuss one of the biggest difference between an average GVD and an effective GVD. So the difference is not always the amount of evidence. Sometimes both companies may have similar evidence. The difference lies in how the evidence is translated into value messages. So let us look at 2 examples. Like I'll show drug X is effective and safe. So now let us think, if we are a payer, can you able to see this sentence, right? So if we are a payer and we read this statement, drug X is effective and safe, what would our response be? We immediately ask, effective compared to what? How effective? In which patients? Based on what study? Like this, all the questions is coming. Was the difference statistically significant? Was the difference clinically meaningful? What evidence supports it? Right? So the statement may be true, but it is not evidence based. It is not differentiated. It does not help the payer make a decision. This is what we call a key weak value claim. If you take another example, like drug X improved progression free survival versus comparator Y in phase 3 trial Z, and we also write the hazard ratio, sorry, hazard ratio is 0.65 and probability less than 0.001, while maintaining a manageable safety also. Okay. This is the whole sentence. Now notice what happened. The same message has become much stronger. The claim now answers multiple pair questions automatically. It tells us what improved. What is improved here? Progression-free survival. And compared with what? Comparator. And where did the evidence comes from? From phase 3 trial jet. And how large was the benefit? That is showing in hazard ratio 0.65. And was it statistically significant? Yes. It is showing probability less than 0.001. And what about the safety? It is manageable safety profile, right? So, so now the treatment is specific, evidence-based, and traceable. So now the second character is traceable evidence. So all claims in the document should be linked to primary sources, study references, and statistical outputs, whatever you will do in the manuscripts and all. If you write some papers and all, the same we would do the citations from wherever we picked it. If the dossiers say the product improves PFS, the trial sources should be clear. If it says there is a reduced hospitalization, the evidence source should be clear. False HTA reviewers check claims carefully. Every claim in the GVD should be traceable back to evidence. If the payer asks where did the survival benefit come from, the company should immediately be able to show that. So then, but if there is no traceability, the payer may lose confidence. Okay. So now the payer understands one minute, guys. So then comes to our consistent assumptions. Now let us discuss the third character of an effective GVD. So there is a consistent assumption should be there. This may be sound simple, but it is one of the most common reasons HTA reviewers challenge submissions. So think about all the evidence components we discussed: clinical evidence, cost effectiveness model, budget impact model, value proposition, and HTA submissions. All these sections must tell the same story. If different sections tell different stories, the payer immediately loses confidence. Let me tell you, example, suppose the clinical trial compares drug X versus drug A. Okay, drug X versus drug A. The clinical section discusses drug A throughout the dossier. However, when the HUR teams develop the economic model, they compare drug X versus drug B. So then the budget impact model used drug X versus drug C. So X is common, but the comparator is changing on all the way. And finally, the value proposition say drug X is superior to standard care. So now imagine you are a payer. What would you think? You would immediately ask which comparator is actually relevant. Why are different comparators used? Which result should I trust? So the evidence may be correct, but the story is inconsistent, and inconsistence creates uncertainty. So a strong GVD ensures that clinical evidence, economic evidence, budget impact evidence, value messaging all use the same assumptions and the same evidence foundation. Okay, so here the key message is effective GVD have one evidence. All should align. Okay, next come to pair relevant messaging. Now let us move to the here one of the biggest mistakes company make in talking, they're talking like a scientist. When they're talking with the payers, they're talking like a scientist. Remember, payers and clinicians do not think the same way. Researchers and payers do not think the same way. HTA reviewers and marketing teams do not think the same way. Each stakeholder asks different questions. Okay, the clinician team says our product reduces IL-6 signaling and inhibits inflammatory pathways. It is scientifically correct. But if you are a payer, what would you ask? Probably, so what? Does it improve outcomes? Does it reduce hospitalization? Does it save money? Is it worth reimbursing? Now let us reframe the message. Instead of saying reduces IL-6 signaling, the payer message becomes the product reduces disease flare-ups, decreases hospitalization rates, and improves patient quality of life. Now the message is payer relevant because payers actually care 5 questions. Already we discussed. Does the treatment improve patient outcomes? How confident are we about these results? Can we justify? Can the healthcare system afford? Does the evidence apply to our patients and healthcare? So if we see our like this, we need to go into the payer shoe and we need to think about this. Then we come to good GVD talks about science, but great GVD translates science into payer's value. Okay. Then comes to local adaptability. The fifth and final characteristic is local adaptability. This is one of the main reasons GVD exists in the first place. Okay, a pharmaceutical company may launch the same product in UK, Canada, Germany, Australia, and India. The clinical trial remains the same, but everything else may change. Already we discussed, right? In India, it is different. In Canada, it is different, and UK, it is different. Okay, so 5 characters of effective GVD are clear value proposition, traceable evidence, consistent assumptions, pair relevant messaging, and local adaptability. So an effective GVT is not simply a collection of evidence. It is consistent, traceable, pair focused, and adaptable value storytelling that helps decision makers understand why a product deserves reimbursement. So a strong GVT converts evidence into decision-making value. Okay, now let us discuss what should remain global and what may be adapted locally. So here the core evidence can be shared globally, but economic and decision-making contests remain market-specific. Let us first look at keep global. Core clinical evidence usually remains global. Pivotal trial data, endpoints, and treatment effects are generally the same evidence base across countries. So the base value proposition also remains global. So the overall product narrative and differentiated benefit claim should remain consistent. So the mechanism of actions remains global. The scientific rationale does not change by country. So the product profile remains largely global. Dosing, administration, and regulatory indications usually come from global or regional regulatory approvals. And if it comes to safety findings, it is also global. Okay, now let us look at adapt locally. Standard of care must be adapted. Treatment guidelines and prescribing patterns differ across countries. Relevant comparator must be adapted. HTA mandate.
हो नहीं
Uh,
जाएगा।
HTA
चलिए,
mandate.
चल ले।
Hello, admit, can you please mute all the other people? So, policy priorities should be aligned with national health system goals. For example, in one country, affordability may be the main concern, in another, equity may be important. So, innovation access may be a policy priority. So the final output is an affiliate ready HTA package. So this reminds the local affiliate receives a market specific dossier built on a shared global evidence core. For example, if you take an oncology product, can look completely different when it reaches different HTA agencies. Imagine a company has developed a new oncology medicine. The phase 3 clinical trial shows improved overall survival, improved progression-free survival, acceptable safety profile. These results are scientifically true everywhere in the world, whether the patient is in London, Toronto, Berlin, or Mumbai. The trial results do not change. The biology of the drug does not change. The mechanism of action does not change. The hazard ratio does not change. The safety profile does not change. This is what we call the global core evidence. Now the interesting part begins. The company wants reimbursement in multiple countries. Each country asks different questions. Let's see how. If it comes to United Kingdom, the clinical trial remain exactly the same. For example, same OS, same PFS, same safety. But what changes? NICE wants UK standard of care, NICE relevant comparator, NHS cost, UK resource utilization, NICE methodology. Okay, suppose the global trial used comparator A, but NICE believes comparator B is the most relevant treatment in UK practice. Now the company must adapt. The economic model must be rebuilt using UK drug prices, NHS hospitalization cost, UK monitoring cost, UK utility preferences. Now the submission becomes UK specific. So if NICE is asking, if you reimburse this product in England and Wales, what is the value for the NHS? This question is no longer global, it is local. Likewise, in Canada, likewise in India. India already we have discussed. So if you talk the component for, if I tell the visual, if you show you usually the component, if you take UK, Canada, India. So take clinical trial. It is take OS, PFS, safety, comparator, cost, treatment patterns. Here, these all are same. So we can directly take all these from the global dossier directly. But it comes to comparator, it will be differ. Okay, it is differing. Then if it comes to cost, here it is UK cost. Then like that, Canadian and Indian cost, and treatment patterns too, it is UK practice and Canadian practice. So Indian practice. So like this, and even if it comes to another differences, budget impact also, UK and HS. And if it comes to HTA treatments, for UK it is nice, for Canada it is CAT, and for India is this HTN. So the science stays global. Yes, the science stays global, but the reimbursement decision becomes local. So every country would need to build evidence from scratch. Okay, so that would be expensive. If you do from scratch, it is expensive, time consuming and inconsistent. So instead of that, the company creates one global evidence foundation. Then each affiliate adapts the relevant sections. This is exactly why global value dossiers were created. Okay. So now we'll close. Now that we understand local adaptation, let us move to the global HTA landscape. Okay. So here, this slide compares four major HTA or value assessment bodies. The key message is that global evidence can be shared, but reimbursement decisions are jurisdiction specific. Let us discuss each agency. NICE covers England and Wales. Its primary focus includes cost effectiveness, qualis, and commonly cited thresholds. So, like that, CAT cover Canada. Its focus includes clinical benefit and reimbursement. And if ICER is based on the United States, it accesses clinical value, economic value, and affordability. Its value assessment framework supports transparent evidence reports, value-based benchmarks, and affordability discussions. And like that, European JCA applies to a European Union context. So it focuses on joint clinical assessment across EU member states. So its unique feature is centralized comparative clinical assessment, while national pricing and reimbursement decision remain separate. So this slide tells us why one evidence package cannot be used identical everywhere. So NICE may focus heavily on quality, right? CAD may emphasize Canadian public payer relevance. ICER may emphasize value-based price and affordability. And UJCA may focus on comparative clinical evidence, while economic decisions remain national. So that's why global evidence may be shared, but reimbursement decisions may remain jurisdiction specific. Now, let us move from agencies to payer expectations. So here, this slide says payer evaluate submissions on two parallel dimensions. One is clinical and another one is financial sustainability. Both are essential. So let us discuss each payer expectations. First one is comparative effectiveness, payers wants to know how the product performs against relevant standard of care. Head-to-head evidence is strong. Is already we have discussed what they'll think of, what they want. Okay, and if head-to-head evidence is not available, indirect treatment comparison or NMA may be needed. And the second one is relevant comparators. And here the comparators should match local clinical practice. Already we discussed India is different, UK is different, USA is different, like that. And trial comparator may be always be the payer's preferred comparator. This is a major reason for HTA challenges. Third one is clinical meaningful endpoints. So payer prefer endpoints that matter to patients and clinicians. In oncology, OS, PFS, HRQL or important. And surrogate endpoints alone may not be sufficient unless strongly justified. And fourth one is subgroup clarity. So payers may ask whether the benefit is consistent across subgroups. For example, biomarker positive patients, elderly patients, severe disease patients, or treatment experienced patients. Okay, like that. So fifth one is uncertainty management. Okay, pair expect sensitive analysis, scenario testing, and sometimes managed access proposals. They want to say uncertainty acknowledged and tested. And sixth one is affordability relevance. And means budget impact should be realistic. The model should use realistic adoption rates, eligible population size, and local cost input, like that. And seventh one is long-term value evidence. That is, payers may ask how long the benefit lasts. If trial follow-up is short, RW registries or extrapolation justifications may be needed. Okay. Like this, 1 minute, guys. So now let us compare evidence expectations across specific HTA agencies. So previously, we have seen what would be the how the payers do not buy clinical outcomes alone, they buy value. Every HTA submission must therefore answer not only whether a treatment works, but whether it provides sufficient value for the healthcare system. So now let us compare evidence expectations across specific HTA agencies. Okay, so this slide builds on a previous slide by showing how expectations differ across all the countries, like all the agencies, NICE, CAD, ISO, UAJC. So for NICE, the expectations include comparative clinical evidence against relevant comparators, full economic evaluation, uncertainty assessment, and committee interpretation of clinical relevance. This means NICE does not look only at trial results. It also looks at economic modeling and uncertainty. So for CAT, the expectations include reimbursement relevance for Canadian context. So clinical effectiveness versus standard of care, budget impact analysis for public payers, system level considerations. This means Canadian context is very important. And when it comes to ICER, the expectations include clinical value assessment, cost effectiveness using QALY and DALY thresholds, broader value considerations such as unmet need and affordability analysis at the population level. So if it comes to EU joint clinical assessment, the focus is joint clinical assessment across EU member states. So here it emphasizes comparative effectiveness and shared evidence review. However, national pricing and reimbursement decisions remain separate. Now let us focus on a key insight. Although methods different, all HTA body wants relevant comparative data, transparent uncertainty quantification, evidence applicable to their decision-making context, professional interpretation. Means the early evidence generation should be aligned with future HTA needs. So if a company waits until submission time to think about HTA requirements, it may be too late. So comparator selection, endpoint selection, PRO collection, utility measurement, and RWE planning should start early. So now we will enter the economic evaluation section. Okay. Here, this slide introduces cost effectiveness analysis and ICER. Cost effectiveness analysis quantifies the trade-off between incremental cost and incremental health benefit. Most of you know this is the comparison is always between the new intervention and the relevant comparator. So the output is usually the incremental cost effectiveness ratio, right? Right? You have in the last classes also, you have seen the current standard treatment, what is the cost and what is the quality. And the new treatment, what is the cost and what is the quality. And incremental cost, what is the cost? So incremental cost is the cost between current and new treatment, right? And incremental quality is the difference between current standard and new treatment. So ICER is something like the difference of the incremental cost by incremental quality. That is 1 lakh rupees per quality. Okay, this is the calculation of ICER. Okay, so the ICER formula is you have seen. So in many HTA submission, the effect is measured as qualis gained. So the result is expressed as cost per quali, like 1 lakh per 1 quali gained. So suppose treatment A is current standard of care, treatment B is a new product. The cost is more than treatment A, but treatment B also gives more health benefit. The payer asks how much extra are we paying for each additional unit for health benefit. So the answer is ICER, what we calculated. Okay, now look at the slides threshold. Like NICE often uses in euros 20,000 to 30,000 and per quali as a reference range, and CAT it is like 100,000 to $15,000 per quali. But it is important to say thresholds guide decisions. They do not determine decisions alone. Okay. Decision makers also look at uncertainty, comparator relevance, model validity, disease severity, and budget impact. Now, let us explain the decision quadrants. If a product is more effective and less costly, it is dominant. This is the best care. If the product is more effective and more costly, it is a trade-off. This is very common for new medicines. If a product is less effective and less costly, the decision depends on context. So when you are writing on the GVD, we need to think about all these things. Then if a product is less effective and more costly, it is dominated and rarely reimbursed. So whenever a new medicine is introduced, payers do not ask only does it work. They also ask is it worth the additional cost. This is exactly what cost effectiveness analysis helps us answer. The most common outcome of the cost effectiveness analysis is ICER, where ICER stands for incremental cost effectiveness ratio. So don't worry about the technical terms. Let's understand the formula, whatever I have shown you now. So like now we have shown the ICER is 1 lakh per quali. What it actually means? It means the healthcare system must spend an additional 1 lakh to gain one additional quali. Okay, that is the interpretation. So the ICER itself is not good or bad. It is simply a measure of value. Let's simplify to understand the quali. The quali combines quantity of life and quality of life into one measure. So now the pair compares the ICER with what they consider. Okay, now let us discuss something very important. Many beginners think low ICER approval, high ICER is rejection. This is not always true. HTA decisions are more complex. Okay. So let us distinguish now. Next, come to the next slide. Let us distinguish cost effectiveness from budget impact. So we discussed cost effectiveness and analysis. And if you come to budget impact analysis, it is different with the cost effectiveness. Okay. So now we are discussing budget impact analysis. It is, can we afford it? These are two completely different questions. Many people confuse them. Let's understand the difference using the practical example. The distinction is very important. The cost effectiveness asks, is it worth the cost for quality? But budget impact asks, can the payer afford it? Okay, if it comes to origin, cost effectiveness usually takes a long-term horizon. It may look at lifetime cost and outcomes, but budget impact usually looks to at 3 to 5 years. If it comes to population, cost effectiveness often focuses on the single patients or treatment course, but budget impact focuses on the entire eligible population. If it comes to output metric, cost effectiveness produces an ICER, budget impact produces total incremental budget expenditure. Okay, so a therapy may be cost effective but still fail affordability review. This is a critical market access lesson. So payers do not only ask, is it good value? They also ask, can we pay for it within our current budget? If you take a professional example, a product may have a favorable ICER, but if eligible population is larger, the payer may request price negotiation. So now if you switch to a payer perspective, the payer is not responsible for one patient, right? The payer is responsible for the entire healthcare system. Therefore, they ask, can we afford 50 crore annually? If you take one more example like this for budget impact, if you take a rare disease and diabetes, okay, and if there are 100 patients who are eligible in the rare disease and there are 10 lakh people in diabetes, and the payer want to annual cost for the one patient here is 50 lakhs rupee and here it is 10,000. It is less, cost per patient is less. If you see this, we are thinking that this is costing less. But if you see in a payer perspective, it is showing 100 crores, sorry, 1,000 crores. But here it is only 50 crores. So what happened? Here the payer is not responsible for one patient. The payer is responsible for the entire healthcare system. Therefore, they ask, can we afford 50 crore annually or can we afford 1,000 crore annually? Now the conversation changes from how expensive is the drug to how much will the healthcare system spend overall. This is the budget impact thinking. Okay. So cost effectiveness focus on individual patient value. So now here the final takeaway? What is the final takeaway? The treatment may be cost effective for an individual patient, but the budget impact analysis determines whether it is affordable for the healthcare system as a whole. So payers must balance value with affordability. Okay, now we will see discuss how ICER are interpreted in practice. So here, ICER is not a binary pass or fail metric. Okay, first we need to think of this is one of the most important messages in HOR. Many beginners think if ICER is below threshold, accepted. If ICER is above threshold, rejected. But HTA decisions are more complex. They do not work like that. Healthcare decisions involve people, patients, budgets, ethics, uncertainty, and societal values. Therefore, ICER is only one factor among many. So we need to understand these contextual modifiers for submission strategy. So now comes to the first modifier, that is uncertainty. If survival data are immature, long-term projections become uncertain. If confidence intervals are wide, decision risk increases. That is why probabilistic sensitive analysis and scenario testing are expected. Imagine you making a very important decision. Would you feel comfortable making the decision if you had complete information? Probably yes. What if you only had half the information? You would become more conscious. HTA agencies behave exactly the same way. When we calculate an ICER, we use evidence from clinical trial. But what happens when the evidence is incomplete? That is what we call uncertainty. Imagine like a new oncology drug. The clinical trial followed patients for only 18 months, but the economic model predicts survival for 15 years. Now the pair asks, how do you know patients will survive for 15 years when you only observed them for 18 months? The company uses statistical extrapolation. But different extrapolation methods may produce different results. One model predicts 10 years survival, another model predicts 15 years survival, another predicted 18 years survival. Now uncertainty increases, right? Similarly, if the confidence intervals around the survival estimate is very wide, the payer becomes less confident. This is why HTA agencies ask for probabilistic sensitive analysis, scenario analysis, and deterministic sensitive analysis. Okay, these analyses help answer what happens if our assumptions are wrong. Imagine you are, okay, next comes to the second modifier, unmet need and disease severity. A product for a severe disease with limited alternatives may be viewed differently from the product in the crowded treatment area. Sometimes serious disease burden can influence willingness to accept higher uncertainty or higher ICER. Here, not all diseases are viewed equally by HTA agencies, guys, because a treatment for a life-threatening disease may be evaluated very differently from the treatment for a minor conditions. So imagine two products. Product A improves symptoms of seasonal allergy. Several treatments already exist. Many alternatives are available. If it comes to product B, treats relapsed metastatic cancer, where patients have very poor prognosis, limited treatment options, and high mortality risk. Now, suppose both products have the same ICER, do you think HTA agency will view them identically? No, probably not. For the cancer treatment, decision makers may be willing to accept greater uncertainty, higher ICER, and additional risk. Even though it's there, they're willing because the unmet need is much greater. Patients may have no alternative treatment options. Okay, so comes to third modifier, the rarity and equity. So for rare diseases, evidence may be limited because patients' numbers are small. Equity considerations may be influence decision making. Some HTA pathways allow special considerations for highly specialized or rare disease treatments. Suppose a rare genetic disease affects 1 in 100,000 people, the company may only be able to recruit 100 to 200 patients globally for a clinical trial. Now compare that with diabetes. Diabetes trials may recruit 10,000 to 20,000 patients. Which evidence will naturally be stronger? The diabetes evidence, because it is recruiting more patients, right? The rare disease evidence will almost always have greater uncertainty because patient number are limited. HTA agents recognize this reality. That is why some agencies have special pathways for orphan drugs, ultra-orphan drugs, and highly specialized technologies. They may accept greater uncertainties because generating large trials is impossible. Now let's think ethically. Should patients with rare diseases be denied treatment simply because they belong to small population? No, many societies believe the answer is no. This is where equity enters decision making. Healthcare systems often consider fairness, social responsibility, equal access, not just economics. Okay. Then comes to the fourth one, budget impact and feasibility. Okay, even if ICER is favorable, high budget impact may lead to managed access or phased reimbursement. Implementation feasibility also matters, right? So, for budget impact, already we discussed, suppose a new diabetes medicine has an excellent ICER, very favorable value for money, but 10 million patients are eligible, the total healthcare expenditure may become enormous. So the payer may therefore decide restricted reimbursement, phased rollout, and managed access agreement. Even though the answer is favorable, if we come to feasibility, imagine a CAR-T therapy, the clinical results are extraordinary, the ICER may even be acceptable, but implementation requires specialized treatment centers, highly trained staff, intensive monitoring, and advanced laboratory support. Now the payer asks, can we realistically deliver the treatment? So the challenge is no longer economics. Here the challenge is feasibility. Okay. So HTA decision is not taken based on ICER only. HTA decision is taken based on ICER, clinical benefit, disease severity, unmet need, rarity, equity, budget impact, feasibility, and uncertainty. Okay, now that is why we say ICER is a decision input, not the decision itself. Okay, now let us discuss the role of real world evidence. Here, if we come to randomized controlled trials, they are essential. They provide high internal validity, but they may not fully answer all payer questions because clinical trials often include selected patients. They may exclude elderly patients, patients with comorbidities, or patients with complex treatment histories. So follow-up may be limited. So comparator may not reflect local practice. This is where RW helps. If you come to RW sources and key applications, RW can help validate trial-based survival extrapolations. This is especially important in oncology when long-term survival data are immature. So RWE can support indirect treatment comparisons or NMA. It can document adherence and persistence in routine use. It can inform managed access scheme designs. For example, post-launch RWD can help validate whether survival assumptions used in the original model were reasonable. If initial trial evidence was immature, post-launch registry data can support reassessment. Okay, so now let us see how real-world evidence strengthens HTA submission and improves payer confidence. So the central message in this slide is that RW bridges the gap between clinical trial evidence and real-world healthcare decision making. So clinical trials are highly controlled and usually include selected patients, but payers want to know how a treatment performs in routine clinical practice. So here comes where RW strengthens the submission. So RW helps shows whether trial results are applicable to real-world patients. In clinical trials, patients are often carefully selected. They may be younger, healthier, or have fewer comorbidities. But in real practice, patients may be elderly, have multiple diseases, take several medicines, and may not follow treatment perfectly. So, RW Health answers, will this treatment work in the actual practice population we treat every day? So, this improves payer confidence because it validates effectiveness beyond the trial setting. And the second one is long term outcomes. Many clinical trials have limited follow-up periods, especially in oncology or chronic diseases. HTA bodies often need long-term estimates for survival, disease progression, complications, and quality of life. RWA can support survival extrapolation and reduce uncertainty in long-term economic models. For example, in a model predicts that patients will survive longer over 10 or 20 years, RWE can help validate whether those projections are realistic. Then comes to next one, treatment patterns. RWE provides practical information on how treatments are actually used. It can document adherence, persistence, switching, okay, health care resource utilization. So this is important because real world use directly affects both clinical outcomes and cost. So this is about the healthcare resource utilization. Then is managed access program. So sometimes HTA bodies may approve a treatment conditionally when evidence is promising but still uncertain. In such cases, RWE supports conditional reimbursement, reassessment, and post-launch evidence commitments. Okay. For example, a payer may say, we will reimburse this medicine now, but the company must collect real world data over in the next 2 to 3 years to confirm outcomes. This helps patients get earlier access while still managing uncertainty. So the next one is comparative evidence. Sometimes head-to-head trials are not available. RWE can help strengthen indirect treatment comparison and network meta-analysis when direct comparison data are missing. Okay, for example, if drug A and drug B were not directly compared in the clinical trial, real-world data sets may help understand comparative effectiveness in routine care. So, like that. So, this is how the RWA strengthen the submission. So, because payers are responsible for real patients, not trial patients, they want to know what happens in everyday practice. Okay, what happens in elderly patients? What happens in patients with multiple diseases? What happens outside specialized research centers? So RWA answers these questions. Okay, so remember our discussion about ICER interpretation. One of the biggest modifiers was uncertainty, right? RWE is one of the most powerful tools available to reduce that uncertainty. The stronger the RWE, the stronger the payer confidence, the stronger the HTA submission. So clinical trials tells us, can the treatment work? But real world evidence tells us, does the treatment work in routine practice? Okay. So now let us move the evidence generation to value communication. So here,
Sharmila, we have last 5 minutes and we want questions also from the participants.
but we have the
Yeah, but
some
because yeah, we
మాట్లాడొచ్చు సో
yeah,
ఎటువైగా ఇవ్వగలరు
yeah, please go ahead. Go ahead.
what happened? Somebody told something.
No, I just put it on mute. Go ahead.
Okay. So okay, I'll take 15 more minutes. That's it, Richard. Not more than that. Okay. Okay. This slide explains. Okay. So
Hello, Sharmila, you're on mute.
Yeah, sorry.
Yeah, go ahead.
Yeah. So in this slide, a pair, clinician, patient, and healthcare system administrator all look at the same treatment through different lenses. So imagine a pharmaceutical company launches a new oncology drug. The clinical trial shows improved overall survival. Okay, like that, other outcomes, other safety data, quality of data, and cost effectiveness, like that. So we are communicating the same evidence differently to different stakeholders. So, and if we take an oncologist, a patient, and a hospital administrator, all uh, all four will care about exactly the different things of the drug. So this is where the value communication becomes important. So first stakeholder payer, the payer is not primarily interested in molecular pathways or detailed clinical mechanism. The payer wants to know, is the treatment worth reimbursing? How much will it cost? How much patients will use it? What is the budget impact? Is it cost effective? What is the uncertainty? Suppose the oncology drug improves survival by 8 months. So the payer immediately asks, what does that survival gain cost? So that is the payer, the HO, he'll think like that. So the HR team may present either budget impact analysis, scenario analysis, and cost effectiveness. Now the payer value message becomes the treatment improves survival well, demonstrating acceptable cost effectiveness and managing budget impact. Notice that the message focuses on value for money. Now comes to the next stakeholder, clinician. Now imagine an oncologist enters the room. The oncologist thinks differently, very different. The clinician asks, does it improve survival? Does it delay progression? Is it safer? Which patients benefit? How does it compare with existing treatment? So the clinician value message is the treatment demonstrated significant improvement in overall survival. And when it comes to patient, his value here, the value message is this treatment may help live longer while maintaining a better quality of life and delaying disease progression. And if it comes to health systems, the value message is the treatment may reduce healthcare resources utilization and improve efficiency of care delivery. So notice that operational efficiency becomes important. One oncology drug for different stakeholders, there is different value message. Okay, then comes to next slide. Okay. So what are the common HTA challenges? So unfortunately, that is not always uh, like good clinical trial is equal to successful HTA submission. Unfortunately, that is not always true. Sometimes a product has excellent clinical results but still faces HTA challenges because the evidence does not match payer expectations. So one of the most common challenges globally is comparator. So comparator mismatch because each for every country, the comparator is different. So we need to go as per the country local adaptation. Okay, so everything there should be good clinical evidence, strong HOR evidence, and clear value proposition. But real HTL submissions challenges one like every clinical trial compares a new treatment against something. So this could be placebo, standard of care, active comparator, or best supportive care. So the comparator selected for the trial may be acceptable for regulators. However, the HTA agency may have a different expectation. Imagine a new oncology. So new drug versus placebo. So why the pair may ask, why did you compare against placebo? They may have different, they may want a different comparator like therapy B. So NICE wants to know how does your product compare with the baby. Suddenly a problem arises. The clinical trial never directly compared the new product against therapy B. Now the company has evidence against placebo, but NICE wants evidence against active standard care. This is the comparator mismatch. If you take a real life exam, so here, but HTA agency they care about relative value, not just absolute benefit. So comparative mismatch can lead to increased uncertainty. So the pair cannot confidently estimate comparative effectiveness. So economic model challenges rise and may reflect the most relevant treatment pathways. Then comes to indirect treatment, indirect immature survival data. So this occurs when follow-up is insufficient and OS extrapolation is uncertain. So here, many oncology trials may follow patients for only 2 to 3 years. However, economic models often project outcomes for 10 or 20 years. So the pair asks, how do you know patients will continue benefiting for the next 15 years? The answer is often based on the statistical extrapolation. So this creates uncertainty HTA agency merits. Okay. So the third challenge is weak utility inputs. So not measuring the UQ 5D utility data. So if utility values are weak or poorly justified, the entire cost effectiveness model becomes vulnerable. If without ratings or customer feedback. The fourth challenge is utilities or like ratings for health states. So the fourth challenge is non-transferable costs. This occurs when cost inputs come from a healthcare system that is not applicable locally. So the fifth one is opaque assumptions. This occurs when model structure and assumptions are poorly documented. So it should be mitigated by providing full model transparency and structure appendix and independent validation. Okay. So now let us see how this risk can be converted into playbook. Okay. So it is first one, it comparative risk. So the global trial. So all the results are excellent. The company prepares a nice submission. Now the company faces comparator risk. So the evidence is strong, but the comparator is not aligned with the fair expectations. So here the mitigation strategy is the company should engage early with HTA agencies. So, and the second one is survival. Next one is survival uncertainty. So in this, the economic model, the HTA reviews are, how do you know these survival benefits continue for 20 years? Because there is uncertainty in the modeling. Then the company only observed patients for 2 years. Everything beyond that is based on the extrapolation. So this creates uncertainty. So here company should not rely on the single survival model. Instead, present different models and then comparisons. Additionally, we can also do some scenario analysis, sensitive analysis, registry data, and real world evidence. So the third one is utility risk. If you are not collecting UQFT from the beginning, then there will be problem with utility risk for the calculations and maps symptom scores to utilities and all. So whenever possible, collect UKFT directly. And then comes to cost transferability risk. This mitigation is to supplement trial-based cost data with local costing studies. So US costs like hospitalizations, physician visits. Now the company submits the same model in India. the reviewer asks, why are you using US cost to estimate Indian value? So the clinical evidence may be valid, the cost inputs are not, because the cost are, we are applying the US cost to the India. So if every country has a different cost. And the fifth risk is model credibility. So if you see if you have a strong submission, you need to identify uncertainties, quantify uncertainties, test uncertainties, explain uncertainties, manage uncertainties. So just keep in mind, uncertainty is not the enemy of HTA. Hidden uncertainty is. HTA reviews understand that evidence is never perfect. What they want to see is transparency, preparation, and scientific. So the most credible submissions are not those claiming certainty, they are those demonstrating that uncertainty has been throughout managed. So that is why uncertainty should be viewed not as a weakness, but as a part of the credible and trustworthy HTA strategy. So these are the pre-submission checklist, okay, like narrative consistency. And first only we need to see all these checklists like evidence transferability, model transparency, local adaptability, comparative alignment, sensitive analysis, risk registry varied, and payer relevance check. So this is the end of the session. So if there are, thank you. Maybe you will get this summary or recording of this session. So these are the references. You just go through these references. Okay, guys? So,
Sharmila, stop
sorry.
sharing the screen. No problem. Please stop sharing the screen. I need to share something. Yeah, thank you. In the meantime, participants, please type in your questions in the chat window. We are here to answer the queries. And I'll just quickly share my screen. So, yeah, thank you all for listening to us. And these are the two links. One of this is for our IHEPR website, another is for our IHEPR LinkedIn page. Please follow and circulate. Why? Because we are coming up with a lot of courses, 5 weeks, 3-day workshop, 2-hour session, 7 months courses, fellowships, executive diplomas. Please feel free to circulate among your friends, peers, and colleagues. Please do, you can scan these QR codes or you can follow these links. Please type in your questions. Sharmila, do we see any questions in the chat window?
Not yet, ma'am. I'm checking and I couldn't find any.
Yes, Samriddhi. Okay. We have also shared the attendance form, right?
Okay, I just saw a question. We discussed about ICER. So in many of the cases, we take net monetary benefit. Can you explain that on that a little bit? This is from Dr. Gunjan Sharma.
Sharmila or Akansha, you want to take it or shall I take? Okay, so when we take ICER, we generally need to have cost effectiveness and also the efficacy. In many cases, it depends on what kind of data it is available. So if it is not available, then we take the monetary benefit. However, ICER is something which is always preferred. Also, Gunjan, we share a lot about this in detail in our various sessions on pharmacoeconomics. So if you see some of the notes and recordings, there you can find much more detailed explanations regarding ICER in that. Thank you. Any other question from anyone? Yes,
Okay.
there is a structure format for GVD. It is available. You can Google it. You will get it. Also for various HTA bodies, a format varies a little bit. You can go and see which HTA body you are submitting to. The table of content where slightly there are appendices. There are certain additional forms as per the requirements for different HTA bodies, and they are easily available on the internet. Any other question, please? Samriddhi, maybe we can close the session then.
Ma'am, just two more questions because they've already been.
Actually, we can, but they are not in the scope of this one. Actually, for that you have
Okay.
to attend our entire pharmacoeconomic. Yeah, because if we start explaining all these things, ISER and cost effectiveness and budget impact, we have to go into the detail of each and everything. Which,
Right, ma'am. I
yeah,
understand.
yeah,
Yes, ma'am. We can close this session then.
yes,
Thank you so
yes.
much.
Thank you.
Much everyone for taking out your time and attending this session. Thank you, Dr. Richa and Dr. Sharmila, for. I think this was a very informative session for all our participants. Thank you so much, everyone.
Thank you everyone for joining us on Sunday afternoon. Take care, everyone. Looking forward to see you all in next sessions. Thank you. Bye bye. Take care, everyone. Bye bye.